Have an exciting agenda lined up. So what we're going to do tonight is truncate the meeting to 30 minutes. So we're going to try to finish on time at 6 o'clock because we have a very special speaker coming, Dr. Winterstein, who's going to talk about mental health awareness from 6 to 7, and hopefully we get some public participation. It's been advertised throughout the township and to schools and everywhere that Superintendent Flanagan could send the information. So we're excited about that. We're going to talk about some old business. We have a couple presentations, and then, like I said, we'll have our mental health awareness talk. So, review and approval of May meeting minutes. Any corrections, additions, etc.?
Move to approve.
Okay, I did notice one correction in the meeting minutes was for Bill 1190. It says Bill 1190. It's actually 1075. So if we can make that correction.
Good eye.
Attention to detail. Okay, so do we approve? Okay. Motion to approve the meeting minutes from May 20th, 2019. Approved. Okay, health officers report, please.
Sure. Good evening. We had 43 food safety inspections that were conducted this month. We had 29 pool inspections that were conducted, including the season openings of our outdoor swimming pools. Just some information, the CDC, and this information went out to the pools as well as a reminder. The CDC reports that drowning is the leading cause of death in the United States for children ages 1 to 4. So with that, the Pennsylvania Department of Health put out a bulletin reminding EMS to report all drownings or near drownings from all regulated public bathing places within 72 hours of the incident. So an inspection can be completed afterwards. Delaware County, and I think I did forward this to everybody in an email, Delaware County put out a press release on the invasive insect from China, the spotted lanternfly. It prefers the tree of heaven, but will invade just about any sweet tree out there and causes a lot of damage. The Delaware County Conservation District is working with the USDA to assess and treat the affected trees on properties in the county. You can go to delcopa.gov for more information, and also Penn State also has a hotline for any questions or if you want to report any sightings. Thank you.
Okay, thank you very much. So I don't know what the tree of, what is that tree? Tree of heaven. I don't know what that is. Okay, good. So we can go on the website and find out, all right, what it is. All right, thank you very much. Just an update on the gas leaf blowers. I will be going to a meeting here in the township July 1st to talk about the gas leaf blowers related to issues around inhalation, issues with the motors and the noise. So if anybody from the board wants to come with me to that meeting, feel free to step up. I'd be thrilled to have your support. And thank you, Dr. Schartz-Hopko, who was in the audience, for that wonderful information. So I will be looking for it. If I can't find it, I'll reach out to you for the PowerPoint, which I would really appreciate.
Can you send out an email to remind us, because I may be able to join you?
Oh, that would be great. So yes, I definitely will.
Thank you.
When and where did you say?
So that's Monday, July 1st, 4th of July week. And I believe it's at 7:30, but I'll let you know. To my email. Thank you, that'd be great. It's a holiday week, so that might be tough for some people. Okay, all right, on to new business. Dr. Capuzzi agreed to give us a few-minute update on measles. We did touch upon that, but I'm not sure it was as thorough as we could have done, just to give some public awareness into the issue of measles.
I'm giving some background too, but I hope to get through this whole thing in 5 minutes, so I'll be fast. This is from a New York Times article, and it kind of came out, formatting thing, but basically we're at a 25-year high in terms of measles cases in the U.S. Measles is a morbillivirus. It's spread through coughing and sneezing, highly contagious because it persists in the air for 2 to 4 hours, There's a hallmark rash all over the body. It's infectious for 3 to 5 days before the onset of a rash and 1 to 2 days before a fever. So somebody could look perfectly healthy and yet still be able to transmit it. Highly contagious, 90% infection rate for unvaccinated people who are exposed to an infected person. And on average, 1 infected person infects 18 unvaccinated people. This is somebody clearly suffering from measles. With measles, a person gets sick for about a week. Rash, aches, fever. 30% of cases have additional complications, GI stuff, upper respiratory, seizures, encephalitis. Most people survive and are immune for life. There is a 5% mortality among affected children in areas where medical care is not great. The history of measles. Measles was first described in the 9th century by a Persian physician. In the 11th and 12th centuries, it was thought to have mutated from the cattle rinderpest virus, so being transmitted from cattle to cattle herders, turned into human measles. Cattle herders then transmitted it to population centers and then trade routes, and it traveled worldwide. In the Americas in the 1600s, Columbus and the European explorers brought measles, smallpox, different things, partially purposely as well, but they did bring measles here. In 1654, there was the first known outbreak. It was in Boston, and the governor of Virginia in 1693 announced a day of humiliation and prayer due to measles. It was taking such a toll. And it is also a significant cause of death during the Civil War. 21,000 measles cases among Union soldiers in the first year. And here's somebody in Boston who was infected, an artistic depiction in the 1600s. So it made its entrance into America, spread through. In 1920, there were 500,000 cases, and as you can see, a lot of deaths, significant amount of deaths. It was managed better later on, but in 1958 to 1962, about the same number of cases, fewer deaths, because it was able to be managed. And measles continued to impact the population till the mid-60s when a vaccine was developed. So this, if you don't remember anything else from this, this is basically good cocktail party talk. The term vaccine comes from the Latin term for cow, vacca. The first real vaccine was developed by Edward Jenner from cowpox pustules that were taken from milkmaids, and that became the first vaccine. So vaccine, vacca. I just learned that. In 1963, measles vaccine was developed. It was a live modified vaccine. And then in 1971, it was combined with mumps and rubella to make the MMR vaccine. Cases in the U.S. after the introduction of the MMR vaccine went from 500,000 a year to just 30,000. In 1978, the CDC targeted for complete elimination, and in 2000, that was achieved. So in 2000, measles, although not completely eradicated as far as cases in the U.S., was eliminated. U.S. cases continued with people coming in the country unvaccinated, or unvaccinated people here traveling and bringing it back from other countries. But in the U.S., it was completely eliminated. So as you can see, the vaccine, we have 700,000 cases a year in 1954, and then after the development of the vaccine, it completely drops. We have another blip in 1990, 1992, because of 2 outbreaks, one in Texas and one in Kentucky. And those were among people who were unvaccinated. So the measles vaccine is a multivalent vaccine, the MMR vaccine. The first dose is given at around a year of age, and the second dose is given between ages 4 and 6. It's over 90%, 97% effective against measles. The vaccine debate really began in 1998 because of the whole MMR autism connection that was made by a British researcher and published in the Lancet journal. That was later disproven, and the Lancet did retract it, but it still impacted vaccination. In England, the people stopped vaccinating basically after this, and the measles cases went from 56 to 1,300 in just 10 years because of failure to vaccinate. So, oh my, you can't even see this. I'm not sure what happened there. So herd immunity is a form of indirect protection from infectious disease that occurs when a large percentage of the population has become immune to an infection, thereby providing a measure of protection for those who are not vaccinated. You all know what that term is, but it applies here. So, as you can see in the top, nobody's immunized, and a lot of people get sick, and then at the bottom, a portion of people do not get immunized, but still, there's protection for the population. Worldwide, most of the world does not have a measles vaccine policy. You see all these areas, zero policy. The mandatory vaccine, measles vaccine for everybody, basically, the communist countries, Russia, China, much of Europe, not the UK or Scandinavia, and then the southern part of South America. The rest of the world is kind of on their own, whether they want to vaccinate or not. The U.S. Green here means that there is vaccination is not mandatory, but proof of vaccination is required for people entering schools. And then this blue part is no mandatory vaccine. There is a policy in it that you don't have to do it. So in the U.S., there are 5 states, only 5 states that require vaccination. New York became the latest state to require it, and it's because of a recent outbreak. But all the other states do not require it. So it's not required, it is required in California, Mississippi, West Virginia, New York, and Maine. Everywhere else, there are religious and/or philosophical exemptions. In most areas, some documentation is needed. In some areas, very little documentation is needed. You can just opt out. In the entire country, though, for medical reasons, obviously, if it's contraindicated, a child does not have to be vaccinated. Pennsylvania, children need not be immunized if the parent, guardian, or emancipated child objects in writing to the immunization on religious grounds or on the basis of a strong moral or ethical conviction similar to religious beliefs. Medical exemptions are always allowed. So, herd immunity in Pennsylvania. The good news is that what really has been established, and you can't see this because of how I did these slides, unfortunately, but the recommendation is that to eliminate the spread of measles in a community, you need 95% of its inhabitants vaccinated. The percentage of Pennsylvania kindergartners who are vaccinated with the required 2 doses of the MMR vaccine is 97%. So we're pretty safe in this state. In Pennsylvania, there are only 1.5%, and the CDC only recommends that states report kindergartners and 7th graders as far as vaccines. So kindergarten and 7th graders, only 1.5%, which is 98.5% of people vaccinated. So our state has a pretty good record. Delaware County, only 0.4% of kindergarten and grade 7 students are not vaccinated. So now we're up to 99%. And in Radnor Township, 3,700 students at the Radnor Township schools, total exemptions, 41. And what the total exemptions number is for 1 or more vaccines, so it's not even specific to the MMR necessarily. Total number of students that are exempt from at least 1 vaccine is 41, which is 0.01%. This report does not include private schools. Some of the private schools do not allow any exemptions. So you can't come here if you don't have the vaccines. In Radnor School District, the parent is required to sign a green card at the nurse's office, no reason given, no approval process. So it's a pretty simple process. I'm going to repeat again that we are in a pretty serious situation. As you can see, from 2010, there were only 60 cases in the U.S., and as of April 26, there were 704. Current outbreak from January 1st to June 6th of this year, there were, as of June 6th, 2 weeks ago, there were over 1,000 individual cases of measles, and 28 states have been affected. The greatest number of cases reported in the U.S. since 1992. Half of the cases were people who were unvaccinated, traveling abroad, and then coming back home. And then these are the outbreaks. There's a big outbreak in New York State, another outbreak in Washington State, and another outbreak in Michigan. This is Pennsylvania. So this big circle is over 100 cases. This little circle is under 10. And these are the pockets. Washington State, there's a strong anti-vaccine sentiment, so that's what's responsible for that. New York, Rockland County, Orthodox Jewish community that for religious reasons doesn't vaccinate. In Michigan, the same thing, Oakland County. And that was the case of an Orthodox Jewish community with travel abroad. And as I said, other countries, and a lot of other countries, they don't vaccinate for measles, period. So somebody who's not vaccinated here is at risk, even when they get on an airplane. In Pennsylvania, we have 5 cases, and they are all unvaccinated international visitors transmitting to unvaccinated family members in Allegheny County. Sorry about that. Medical exemptions from school vaccination requirements. We're just going to forget this slide. Okay. Getting towards the close, I just want to mention, so the arguments to combat the belief that vaccination requirements are in violation of individual liberties tie into the fundamental belief that an individual shall not have protection of liberties if they are in direct opposition of another person's individual liberties. If a person chooses to leave him or herself susceptible to illnesses that can be passed along to another, the government has a right to do all in its power to protect the individual like a baby who did not choose to not become vaccinated. And who said this? I'm sorry. I forgot to document that. But so the idea that, you know, we should be able to make the choice, but then again, you're also choosing for other people, and it endangers them. Art Kaplan, who is the medical ethicist, said, in regards to this, that children have a right to the best available medical care, including vaccines, regardless of parental opinion about vaccines. Quote, arguments about medical freedom and choice are at odds with the human and constitutional rights of children. When parents won't protect them, governments must. So that's his stance, and it seems to be a reasonable one, actually. Here's the thing that's my main concern. It's not only the children who can't decide for themselves, but this is something that was staggering to me. So the MMR vaccine, the measles vaccine, came out in 1963. That's great. All these kids got vaccinated. I had always assumed that the adults got vaccinated too. Adults of that generation, for the most part, are not vaccinated. They're vaccinated for the flu, they're vaccinated for shingles, they're not vaccinated for the measles. And I'll say, just in personal experience, my mother was just in the Middle East a month ago. She's not vaccinated. And who knew? Who knew that this was such a risk? But I think doctors don't really talk to even this whole generation, and there is a whole generation of unvaccinated people among us. Had she brought measles back, which could have been pretty easy to do since it's rampant in other parts of the world. Had she brought it back, we've got kids in Radnor Township who are not vaccinated. And then, here we go. Senator Dalen Leach introduced legislation to eliminate vaccine exclusions for philosophical, religious, and ethical reasons in children prior to starting school. So we'll see what happens with that. Any questions?
That was outstanding, Joan. Thank you
thank you.
so much. You put a lot of work into that. So really appreciate the historical perspective, something about herd immunity, which I don't think a lot of people are really clear about. So that was well explained. And then looking at PA, local, and Radnor in terms of numbers, which I'm really impressed that you were able to find. So it sounds like we're in good shape in the
I had some
township.
help.
And I'm sure Marie,
Marie.
thank you so much. So that really kind of rests assured. But I think if, people watching this or have a question, you really need to speak to your primary care physician.
Yeah.
And maybe if you're traveling abroad, that sort of thing, really consider the getting the measles vaccine. So that's a really good case in point where you talk about people before 1963, being born at that time,
Yeah,
possibly getting the vaccine.
okay.
A lot of that age group actually had measles, so were immune.
Yeah,
Through
a lot
that.
of that age group did. And but you did too?
Yeah.
Okay. But and I don't know what percentage have, actually, and that's not something I looked into, but that's an interesting point. But there are also a lot of people who didn't have it and who have no immunity. My mom being one of them.
Thank you very, very much. Really appreciate it. All right, would our student interns like to come up? So Philip and Lou will talk about their projects. So we were really thrilled to have them this year, and they participated in every meeting, and we're part of Teen Health Week nominees. So if you want to talk into the mic and tell us a little bit about your project, that'd be great.
Okay, so my name's Louis Minning. This is Phil Kaplan. We've been student interns on the board since October, and we prepared this presentation on adolescent sleep, very prominent issue right now in Radnor. So on April 23rd, 2019, the school board voted 7-2 to pass delayed school start times in all of our Radnor schools, public schools, and with a few goals. Number one, instructional time was maintained at the high school. It's about 40 minutes each class. And they're going to do annual surveys repeatedly, assessing things like screen usage, athletics, transportation, sleep, homework, and study habits. A lot of these are very important and relevant to sleep because, for example, screen usage, being on screens a lot can affect your sleeping hormones. They're also hiring 2 new bus drivers and ordering 2 new buses because there's going to be a lot of overlap within the bus routing system. And that's paired with the development of the Here Comes the Bus app, which allows parents and students to track where their bus is.
So we also listed some of the most important benefits that we hope to see as a result of this resolution, and we kind of organized them into categories titled academic performance, mental health, and physical health. So some of the most important benefits we hope to see were improved alertness, memory retention, and cognitive processing skills. And in the mental health category, we hope to see reduced rates of depression, anxiety, and suicidal thoughts and behaviors. And the physical health, we hope to see a reduced number of car crashes, reduced risk of stimulant and other substance abuse, and high-risk health behaviors, which are especially important in teens. And all of these, the resolution passed meets the recommendation of the American Academy of Pediatrics, CDC, and the American Medical Association.
Other schools in the country have also delayed their start times for the same reasons. The National Sleep Foundation's followed 7 schools in Minnesota who did this change. And what they found is that each student on average had about an additional hour of sleep every day, about 5 hours a week. Attendance and enrollment rates improved. One thing to note is that schools that started at 7:15, their control group, they reported about 4 times as many tardy students compared to the 8:30 schools. And finally, student-reported depression decreased.
So, yeah, so we went out and kind of surveyed students as far as what they thought of the new resolution. And we found the most common concern expressed by students was that they're going to end up staying up later at night because school was pushed back a little bit further. And I also shared this view at the original onset of that resolution being passed. And we also found that teachers voiced concern over traffic with the new Penn Medicine building. And in addition, many individuals voiced concern over coordinating sports schedules and with other Central League schools, since they'll be operating on a different schedule, and the timing of games may result in Radnor students missing core classes. So an important thing that was that the Radnor administration is hoping to do is they will be giving students who are athletes an 8th period gym. So therefore, games with earlier start times will not impact student attendance of core classes. And in relation to the worry that they will stay up later, the American Academy of Pediatrics suggests that a later start time will not result in students staying up later. However, it's still important that students exercise good study habits. And some study habits that we suggested would be to limit screen time and also avoid working with distractions such as one's phone while they're working. However, we were looking for any solutions to the Penn Medicine building traffic problem, and we didn't see any current suggestions that may result in decreasing conflict with traffic.
So next spring, after a year of trying this new schedule, the school board, along with the Radnor School Start Time Committee, the high school, made up of students and teachers, they're going to reevaluate all the successes and maybe failures of the new start time. One of the things they're going to especially look at is homework and how it relates to coming home late, especially for athletes who might be coming home like much later in the evening. How are they going to get their homework done in a timely manner before even midnight, 11 o'clock midnight? Could be very detrimental to their health. So they're going to reevaluate that in a year, see if it's working. Here are our sources for all of our references. Thank you. Do you have any questions?
That was outstanding. Thank you so much. It was really, really good. I think you hit all the points. I think it'll be really interesting. So maybe as a board, we might want to invite whoever queries those specific metrics in terms of sleep. I'd like to maybe have them here. I don't know what the board thinks, maybe late next spring, to maybe see what has happened, if they give any feedback or that sort of thing. So we'll put that on our to-do list for the future. But thank you so much. And it's really been a pleasure having you this year. Any other questions? Questions? All right. Well, great job, guys. Thank you very much. Quickly, before our next speaker, I know Gail Morrison wanted to come up for public comment. Gail, did you want to say anything? So Gail forwarded us some information, the board, about PA House Bill 1075, which is the ERPO bill. So you did you sent a resolution, a tentative resolution, so I know.
Yeah, it was just so you had a starting point.
Okay, so if you just want to give a minute or two before our next speaker. that'd be
Okay,
great.
right, I didn't read it. I think you all had a chance to look at it. I'd be interested in any feedback as well, because I think, as I mentioned, I'm part of some groups in the whole kind of Metro Philadelphia area, and we look at this as possibly a way to get this to other boards of health, whether township or county, and they can consider a similar resolution. So if you all have any feedback. I did get some feedback from Ceasefire PA that they just added some language that included the 14 other states who have already passed them, so that everybody knows it's not, unknown territory. There are 14 states that already have ERPO laws, some including conservative states, some, as gun-loving is a bad way to put it, but Indiana passed this law, Florida passed this law after Parkland. It has shown via research to reduce gun violence, to reduce suicides. There's been some very sound research about that, that Johns Hopkins has done. So I guess I'll stop there. Does
So,
anybody-
yeah, if you want to forward the research to us, if you have any pertinent
Yeah.
articles, and then I would ask the board, I'm not sure how we want to move forward with this, because I think it does deserve more time and discussion before we sign this and editing.
Yeah, where are we? This is
I
your
think-
last June meeting, right? Okay.
Yeah, I think it
Yeah.
does.
The
to-
legislative session ends at the end of the, is Sarah here? She's outside. I wish she was here because she's,
Gail, I forwarded you the questions that I had. Were you able to get any answers on that? Are there any details in this bill, or,
is there any
I
detail?
mean, I love the spirit of it. To me, it's a
Yeah.
no-brainer, but
You read the whole bill or the memo?
I read what I thought was the whole bill.
Okay.
And I didn't see a whole lot of detail as far as like looking at all those, special
Yeah.
situations, contingencies, exactly what are they thinking? And without those things being addressed, I would not be in favor of it, because I think it would provide a false sense of security without, like, how are we going to deal with all these other situations, like a gun still in the house, or when do you give the gun back? Who's holding the gun? Who's
Well,
keeping
okay,
it?
but
Search warrants.
I gotta tell you, the feeling from an awful lot of people is we err on the side of caution, not think we're going to analyze every single possible contingency. I think that law enforcement wants these tools and has advocated for these tools, and they have been, this bill has been in process, it's in its second year. The Pennsylvania Sheriff's Association has signed on to it, the ACLU has signed on it. There is exorbitant due process in it. Judges make these determinations. When we sat with our own Sergeant Dietrich, he said, when we have to go into a home where there are guns, we just execute what the judge puts on a piece of paper. This would be a valuable tool for us, because the police get put into situations where they're supposed to make a split-second decision about,
Right.
they're in the middle of a domestic dispute, they're with a teenager in crisis, do they remove the guns or not? This law makes it so that a judge has ruled that they should remove those guns until this person can get help. So that is paramount to me. So when we have traveled to Harrisburg, it is very difficult to sit there and watch people debate the rights of gun owners before thinking about the aftermath of these situations, the aftermath of school shootings and teen suicides. It's the unimaginable. They're never whole again.
I'm on your side.
So,
I mean,
okay.
but I don't,
Yeah,
I
it's
don't
just-
even know that it goes far enough. That's what I
Oh,
think.
okay.
And the other thing is, it doesn't address every situation that we've had in this township, as far as I'm aware,
Well,
has
that's where
involved
I do
people
have some
who have no
statistics for you.
issues,
That-
no known
that's-
issues.
That might be a little bit of a misconception. In the case of all school shootings that have been studied, 78% of the shooters reveal their plans ahead of time. And Chief Flanagan told us that as well. They learned that in their training about trying to prevent these. They broadcast these things, or they put it on social media, or they're telegraphing it. They feel this way, they're upset, So again, 78% of the time, 87% of the time, they have shown signs of being in crisis. So
Given that
we had no way of knowing that's not true.
Right, that might be the case, but given that that information never filtered to any people who had the capacity to deal with their gun situation or chose to,
But I think
nobody would have made them.
We need healthcare professionals and people like you all to have more of these conversations. In the case of this Wawa shooter, our own DA stood on the steps of the courthouse and said, we don't know what was in the heart of that shooter, but this could have made a difference in that situation in what the judge heard last September on whether he was deciding to renew the restraining order, for instance. So these are relevant, and the more we are talking about it, the more, if somebody says my teenager is suicidal, if you all talk about it and this makes it in the papers, then there's a chance that a parent's going to say, my gun is not secured enough, or my gun, I should get out of the house until we're through this. Because there are some really tragic cases of people who they call gun stores and beg them not to sell to their son or daughter in crisis.
So I think I hear you 100%. So
Okay.
when is this due? When do we need to have?
Sarah, Christus, can you bring Sarah in?
Well, you know what, why don't we talk
Because,
offline? Let's talk offline, and then maybe we could convene a
Okay,
subgroup
yeah.
of us to
As
meet
I
at another
understand it, a
time.
bill has to get reintroduced every legislative session, and the legislative session would end June 30th. But, everybody's checking out for the
All
summer,
right,
so I
so
understand.
let's send the literature,
Okay.
what the relevant data
Yeah.
is, and then we'll decide as a group offline if we
Right.
need to meet at another time and date shortly.
Okay.
And figure this out and sort out the questions and details.
Okay, yep, that's.
In the respective time. All right, thanks, Gail.
Thanks.
Linda, can I just put on the record that, I do think that the board is very appreciative of you coming to bring this. There can be nothing more important to us than the safety and wellness of the children in our schools and those in our community. So I think that all of us are willing to meet if there's a deadline vote. And maybe we need to discuss whether this is even something that we want to do from a public health point of view or not. But, I think that all of us, my recommendation would be that all of us either have a vote on this and either decline to vote on it or vote on it with respect to what you brought to our attention. So we may decide that we don't.
Because we're active in this, we spend so much time immersed in its daily. Oh, okay. Well, I just wanted to say that I'm sorry that I get a little hopped up.
You don't have to
about this,
apologize
but-
for your passion.
We shed a lot of tears when these things happen, when that family, the husband and wife on South Wayne Avenue, when the young man, I don't want to mention people's names for the privacy of the family, but it's really happening all over, and it happened here. So,
Thank you
Thank
so
you so
much.
much
We
for
really
bringing it.
appreciate it. Thank you so much. All right, so we have our guest speaker. So we're going to bring people in for our presentation on mental health awareness.
Okay, and this is also, I wonder if you're walking. And there should be a clicker. Okay. Are you ready?
Are you recording it? Okay, so what's my width of walking?
Uh,
I have a remote control, I'll follow you.
Perfect, I love it.
Use either this or do it.
I'll just use this. It's easier.
You ready? Good evening, ladies and gentlemen. My name is Jane Karabasi, and I'm a member of the Board of Health. On behalf of my fellow members, I would like to welcome you to this evening's presentation on youth suicide prevention. As many of you know, suicide is the second leading cause of death among Americans aged 10 to 24. Last year, Radnor Township was devastated by the loss of a young life to suicide here in our own community. This tragic event prompted Police Superintendent Chris Flanagan and Commissioner John Nagel to reach out to the Board of Health asking about suicide prevention initiatives and programs in our community. I volunteered to conduct an informal survey of local public, private, and parochial schools at the middle and high school levels to obtain information about suicide prevention programs and initiatives present today in our schools. Findings revealed that programs and initiatives in these schools vary greatly in scope, with the Radnor Township School District having the most comprehensive program of all the schools surveyed. The board then decided to plan a community presentation on this very critical issue. At the recommendation of psychologist Dorothy Lowry, student assistance coordinator and crisis coordinator with Radnor School District, I contacted Dr. Matthew Winterstein, who agreed to be here tonight to discuss with you the present-day status of youth suicide and prevention with a Q&A session to follow. Matthew B. Winterstein, Ph.D., is Associate Professor and Director of Research in the Division of Child and Adolescent Psychiatry at the Sidney Kimmel Medical College at Thomas Jefferson University. His grant-funded work supports his role as facilitator of the Pennsylvania Higher Education Suicide Prevention Coalition, a collaborative partnership among nearly 100 campuses across Pennsylvania and beyond, designed to support one another in developing meaningful and effective methods of reducing suicide deaths on campus. Dr. Winterstein has served on the national and international task force convened by Suicide Prevention Resource Center, the American Association of Suicidology, the American Foundation for Suicide Prevention, the National Suicide Prevention Lifeline, Suicide Awareness and Voices of Education, and the National Institute of Mental Health. He was a consultant to the National Center for the Prevention of Youth Suicide. Dr. Winterstein presently serves on the executive board of the Pennsylvania Youth Suicide Prevention Initiative. He has authored and co-authored numerous articles and is a frequent speaker to community and professional groups. Please welcome Dr. Winterstein.
Thanks, Jane. Thank you, board, for having me. Appreciate the invitation to be here today. And thank you all for your attendance this evening. It's always a humbling experience to talk in front of a new group. And I fully recognize that while I stand here before you, there are people in the room that I'm sure in some capacity have been affected by suicide. And so it is not a simple conversation to have. It's an important conversation to have. And I'm going to do the best I can to cover some information tonight that I think will be useful and helpful for you. I wish I had the answer to everything. I do not. But I do want to present to you guys some information that I think, like I said, that I hope that will be helpful for you. Yes, backwards, wrong way. There we go, that way. So this is my agenda for the evening, if you will, and I will do the best I can to get through it quickly. So we'll talk a little bit about some myths that I think are important, because I think one of the challenges that we have, particularly with youth, is that we think certain things about how youth are working around suicide and thinking about these kinds of issues, and sometimes we're right, which is wonderful. Other times we're not exactly right, which impacts the way in which we address them. I'll give a little bit of data and talk about how Pennsylvania compares to the nation when it comes to suicide and suicide deaths. I'll talk about different prevention strategies and then share some resources with everybody at the end. So here's a few myths for you. The first is this, that suicides happen without warning. Now, for those of you that may have been impacted by suicide at some point in your lives, you would say that's probably true. Because if we had been able to predict the death of any particular person, obviously we would have done things differently. It's just the reality of the way this sometimes works out. However, what I can tell you is that most people who die by suicide, and certainly those that make suicide attempts, have communicated this to somebody at some point in time. And certainly through social media and a variety of other mechanisms out there, youth are communicating how they feel frequently to people. The problem is that those avenues by which this communication is occurring is often saturated with different messages such that they don't recognize when a message is concerning and when it is not concerning. And so just one quick example is that we went to the Crisis Center in Philadelphia several years ago with a really bright student from Swarthmore, looking at social media and suicide risk, and we asked a bunch of individuals who had come in through the Crisis Center, some of whom were suicidal, some of whom were not, about what were the last 5 things they posted on social media about how they were doing. We then had ratings about suicidal thoughts, suicide attempt behavior, depression, things of that nature, and we're able to kind of, to some degree, rank order people as these are the highest risk group, this is sort of the middle risk group, and even though we're in a crisis center, I'm going to argue this was the lowest risk group within that context. And we took those statements and said to a group of quote-unquote normal kids, right, what, if you saw this statement, how concerned would you be, and what, if anything, would you do? And of course, what we found was they weren't concerned about anything that they saw, and they wouldn't do anything about any of this. And when you went back and asked them about, well, help me understand this, it was, I see this stuff all the time. How am I supposed to possibly know when I'm worried about, when I should be worried about somebody and when I shouldn't be worried about somebody? So it's a problem. Some people think that suicide is an act of anger, aggression, revenge. Somebody's trying to get back at somebody else. Now, I can give you the obvious version of this, which is I'm a clinical psychologist by profession, and so I've worked with lots of people who have been angry at other people from time to time, all of whom, if they've ever done anything in a vengeful kind of way, wanted to see somebody else's reaction to that. This does not happen that way, of course. The bigger issue and the more intelligent way, I think, of thinking about this is that most people that are suicidal are not suicidal because they're angry at somebody else. They believe that they are a burden on other people, that whatever is going on in their life in some way is being taken out on somebody else, and they deserve better. The other person deserves better than what they are putting upon them. In other words, if I end my own life, that other person's suffering will end because they won't have to deal with me anymore. And so it's completely different than I think this myth that they're angry and aggressive and after people kind of from that purpose. This next myth is the one that's kept discussions about suicide out of schools for years and years and years. Now, I will say that Radnor School District has been a champion, I think, probably in the entire state, in terms of doing work around suicide prevention. We have a large grant that's been funded by the federal government that goes to the Office of Mental Health and Substance Abuse Services for the state of Pennsylvania, where we then go into schools and we work with them around educating teachers, a lot of things that I'll talk about as we move forward. And Radnor has been there since day one. Anything and everything we would offer, it's all free stuff, so I don't know why nobody else takes us up on this thing, but Radnor's been, yeah, come to our school. And so Dorothy has been a fantastic person to partner with around that. We've been in the schools here for a long time doing a lot of different stuff. But this myth has really been what's kept the conversation about suicide out of schools for a long time, because the belief was if you show up at school and talk about it, you're going to make people suicidal. Now, I can say it like that, and you can all go, that's ridiculous, it doesn't make any sense. Tell that to a school administrator. Now, the smart way of doing it is not to go into a school in front of an auditorium of 500 kids and talk to them about suicide risk and all the warning, the important conversation is, what are the warning signs? What can you do for yourself or your peers if you're worried about it? And oh, by the way, there are some secrets that are better left unkept. Do not keep this a secret, go tell somebody. But you want to do that in small classrooms, because the problem is you have no idea the impact on a large group of people and who is dealing with this in a different way. But if you were to go to a school and say all those things in front of that school and tell them all the right stuff, guidance counselors at the school district would tell you there's going to be dozens of kids lined up outside of their door that afternoon telling you either they have thoughts of suicide or they know somebody who does. That has led to people for years believing that having that conversation suddenly makes somebody suicidal. I would argue not the case at all. In fact, there's data that suggests there's no what we call iatrogenic effects. In other words, talking about suicide does not make anyone suicidal. If you ever have a conversation with somebody and you're really concerned that they might be suicidal, if you ever ask them, are you having thoughts of suicide? Trust me, you did not plant that idea into their brain. you probably freed them up to actually have a conversation about something that they feel so ashamed of that they couldn't talk about it until you asked them. So talking about it does the exact opposite effect. It's not about shutting people down. What it does is it gives us an opportunity. Somebody now says, I'm hurting. And guess what? When they say that, now we can do something. We have an opportunity to intervene. All right, some of you guys are a little bit younger in the room, so I normally say this to an older audience, but what's wrong with this statement here? For all of you over like 40. When you're older, the rest of you guys will get it too. Take out the first word and read it again. This is an adult belief, right? Teens overreact to everything. Every adult believes this to be the case. Why? Because we went through all these things, we think. And we got through it and we're okay. Therefore, when some kid comes to me and says, hey, this is what's going on and I feel terrible about it, we think it's going to be okay, don't worry about it. Sometimes we say that. You know what happens when we say that to a teenager? They think you don't have a clue. And I have zero interest in communicating with you about how I'm really feeling because you don't have a clue what's going on. What doesn't seem like a big deal to us as adults in the moment can be a very big deal to somebody else. And I'm sure if we all take a few minutes and think about our own childhood and adolescence and growing up, there have been times where something was going on in our own lives that we thought was a really big deal. And as adults, we look at it and go, it probably wasn't that big of a deal. But in the moment, we certainly thought it was. And we also have to remember that the perception of something bad happening can actually predict whether or not somebody engages in a suicidal behavior. It isn't that some kid needs to fail a test for them to feel awful. But if they come home from school that day, absolutely certain that they failed the test, even though the grade hasn't come out, that can be problematic as well. It takes a while for kids to realize that, like physics and stuff, like they curve those grades sometimes. But when you see that 67 on your first exam and you've been getting A's your entire life, you think that's not me. And then the last one, again, difficult pill to swallow for those who've been affected. And I'm not saying that it isn't the case that some people feel so desperate, so alone, that it gets to the point where doing something helpful is very, very difficult to do. What I'm arguing, though, is that people, all of our lives are on a trajectory. At some point in time, we have the ability to change the trajectory of anybody's life. We sometimes don't realize what we're doing that actually is making that impact. I've spoken to many, many people who will tell you about somebody who's changed their life who had zero clue that they actually did anything to be helpful. Most people, when they're suicidal, particularly young people when they're suicidal, that acute crisis, in other words, those moments when it's like, I cannot live anymore, those things go away usually in a matter of a couple of days. Now, the problem, of course, is they come back sometimes later on. But in the moment, they last for usually a short period of time. If we can be helpful during that short period of time, we can make a difference. And from a clinical perspective, what I will tell you has been very, very helpful for me to do. I'm one of those people that I get referrals from other psychologists in Philadelphia, like they refer their patients to me, like this person's now telling me they're suicidal, can you see them? And I just sort of think there's a problem with our system that our mental health professionals feel like they have to then refer somebody on to another mental health professional when their patient says something like that. But I always ask people, I say, what got you here? It's never mom drove me. That's not what I'm interested in. I'm interested in the darkest moments of your life, somehow you've ended up getting to my office. How did you get here? And I will tell you, most of the stories sound something like this. When things were so awful that I didn't want to exist anymore, and I wanted everybody to go away. And some people later on will tell you I was pushing people away. In other words, I feel so terrible about myself that if I treat you horribly and you say he's a jerk, I go, that's it. You just prove the fact that I'm a jerk. So in those darkest moments where I didn't want to be around anybody, I'm sometimes actively pushing people away and just disengaging as much as I possibly can, somebody wouldn't leave me alone. And I don't mean literally sometimes, I mean figuratively. They would not leave that person alone. Is everything okay? Oh, yeah, I'm fine. keep in mind, if you ever ask somebody if everything is okay when you think that things are not okay and they say fine, when we buy that answer, that's because we want them to be fine. If we don't think that they're fine, then you say, well, hold on, I'm concerned and here's why. But these people said, I still pushed them away. And I'm pushing, and one person would not be pushed away, and that person is ultimately what got me connected to whomever who got me here. So in other words, caring, concerned individuals can help someone when they're in a crisis, and if you listen to people and take their feelings seriously, you can truly, truly save a life. All right, so those are just some myths to sort of set the stage for us a little bit. I'll give you some data. I don't want to give a lot of data, but I was asked to give some data, so I'm going to give some data. And this is a wonderful data slide to start with, right? At least it's huge. Like sometimes I give this presentation, it's on like the size of your crest on the wall there, and people are like staring at it going, I can't read that. So the group that I primarily work with is sort of this 15 to 24-year-old age group right there. Now you can't read the numbers very clearly, but I think it's 6,200 suicide deaths in 2017 in that age group right there. I do a lot of training at our medical school, and I work with our medical students. And they get really anxious about all these white boxes because these white boxes are all of the non-injury-based medical conditions. This is all the stuff they're learning about. They're sitting in classes, having discussions, learning about cases, and this is all the stuff that they study. And I ask them, how many of you are interested in pediatrics or adolescent medicine? There's always a few of them that are interested in that. This is, if I take our large medical school and break it down to smaller groups, that's what you get, a couple of them that are interested. And I say, look, if you take that 15 to 24-year-old age group, and you take the 7 leading non-injury-based medical conditions, all the white ones, and add them up. And just for fun, let's throw the next 10 that aren't even on that list below that, throw that in the mix too. There are more kids in this country that die by suicide than everything they're going to learn about in medical school combined, unless they go into oncology or emergency medicine. That is about the only exception to that. They listen. And that's what we need. We need them to listen. This is looking at suicide rates, looking at males and females across the lifespan. And what you can see is the slope of the lines, so the angle of these lines here, are exactly the same except for 2 places. The first is here. That's the group we're talking about today. And the second is here. But with the exception of the massive hike that happens there in adolescence, that slope, there's no difference, really, when you look at middle-aged adults. There's certainly more males that die by suicide, but there's not a gender difference that really happens right there. What happens in older age, we think, has to do with connection and just sort of historical, cultural values that have been played out for years and years and years that individuals in their 70s and 80s, oftentimes the women are doing a much better job of being connected and having communications and conversations with other people, whereas the men are more disengaged. That's not the only answer, but I think that's part of it. All right, so how does Pennsylvania compare to the nation? So let's take a look. So nationally, this is 2016 data, because believe it or not, even though like the CDC has our state data, if you go to the website where you can actually get our state data, it doesn't have 2017 data on there, it has 2016, so I'm going back a year. So just under 45,000 people in this country dying by suicide in 2016. If you look at ages 10 to 14, 436. So the rate, what that means is per 100,000 people. So 2.1 is per 100,000 people. That number is the number that's more important when it comes to this, because if you just look at total numbers, that doesn't really tell you anything, because it's looking at census data. And then in the 15 to 19-year-old, just over 2,000 people. Pennsylvania, we had just under 2,000 people die by suicide in 2016. We had 18 people between the ages of 10 and 14 die by suicide, which was slightly higher than the national average, and we had 78 people between 15 and 19 die by suicide, which was slightly lower than the national average. The only other data point that the federal government breaks down is like what percentage of them had to do with firearm deaths. So if you look at firearms in the nation, almost 23,000 people across all ages using a firearm as a method for suicide. So 51% of all suicide deaths were firearms. 10 to 14-year-olds, almost 37% were firearms. In the 15 to 19-year-olds, 44, almost 45% firearms. Pennsylvania, the overall rate is slightly lower, but it's higher for both groups when you're looking at youth. Not by a lot, but higher. Nationally, we know that 53% of firearm deaths in 2016 were ruled as suicide. So if you look at all firearm deaths, 53%, almost 54% of those nationally were suicides or ruled as suicides. In Pennsylvania, almost 64% of firearm deaths are suicides. The CDC data, so what happens is the county collects data, the county data then goes to the state then sends the data down to the CDC. For whatever reason, I can find 2017 data for the CDC, so the national data is available. There's a system in PA, the Department of Health, called EDDI, that you can go on, you can look it up yourself, but it gives the best you can get is 2016 data. They send it to the CDC. It just hasn't been published yet. It will be out soon. Yeah, but you can see there's a huge difference. That's a pretty big difference. 64% of deaths by firearms in this state are suicides. All right, so let's talk about prevention strategies then. There's several different things. I'm breaking them up into simple groups, which are very complex in and of themselves, but we don't have time to get into all of them in great depth, but I do want to share some of them. So there's school-based approaches, community engagement, which I'm going to summarize in a couple of different words. We'll talk about local media. And sort of the impact and how we can do those kinds of things a little bit better. We'll talk about lethal means restriction and then continuity of care. So school-based education programs, typically the stuff that happens in schools are one of two things. It's going into schools and training teachers, training school counselors, training school psychologists. The teachers, it's how to identify kids that you should be concerned about, and then how do you engage them enough to get them to the next level. And the next level, folks, it's how do you do a proper assessment, how do you determine when crisis needs to get on board, and how do you get them out of your building into a proper level of care. There's several different programs that are out there. Two of them that we've done quite a bit in Pennsylvania already. There's a program called QPR. QPR is called Question, Persuade, and Refer. There are lots of different versions of it. There's a version for school teachers. Again, it's really about how do I identify when somebody could be at risk, and then if I'm worried, like how do I have this conversation, and then can I get them to the next person? More Than Sad is a program that the American Foundation for Suicide Prevention has put out. It's a video program. They will tell you that it's a little outdated in terms of like the videos themselves could use a little refreshing. Our research team that's been working on this state grant, which is the next thing listed there, actually did an evaluation of More Than Sad just a couple of years ago. What we found is that it actually works in helping school teachers identify kids who are at risk. That's really the point of it, and it worked. So we had some pretty good data on that. I mentioned our Pennsylvania grant. It's under the Garrett Lee Smith Memorial Act, and so it's funded through the Substance Abuse and Mental Health Services Administration, which is a part of the Department of Health and Human Services for the U.S. We've done these kinds of trainings. We've done a variety of other kinds of things. Act 71 was passed 5 years ago, which requires teachers in all public school districts of grades 6 through 12 to receive 5 hours of suicide prevention, or 4 hours of suicide prevention education every 5 years, which doesn't sound like a whole lot, but compared to 0, it's a lot. Sometimes when it comes to like working with legislators, it's like we start somewhere, and that's better than nothing. And so we have programs that we run out into the schools. We developed an online learning site called PreventSuicidePALearning.com. Anybody can go on there. Everything on there is completely free. There's courses for teachers, there's courses for clinicians, and so on and so forth. And if you want to know more about what's being done in schools and the different programs, there's lots of programs. But if you want to know about the lots of different programs that have been vetted out there, that website at the bottom, so preventsuicidepa.org /Act 71, will get you to a website that has a list of all of the different school-based prevention programs that exist out there. We have them organized by what age population we're working with, so whether it's high school, middle school. There's very, very, very few things for elementary school. So it's organized by that. It's organized by cost. Some of them are free. Some of them are very much not free. The ones that are not free are not necessarily better than the ones that are free. Just putting that out there. So it has a lot of information on that. So these are the school-based approaches that are out there. Community engagement, I'm going to summarize in the same word 3 times, which is connection. We were having a conversation earlier about how, like, talking about gun locks and how do you get these out into the communities and stuff like that. And I was saying we've got a partnership through Prevent Suicide PA with the Philadelphia Phillies of several sports teams in the state, but the Phillies are obviously the local team. And we do a suicide prevention night with the Phillies. And so this past April, we had our suicide prevention night. We show up there, 35 or something thousand people also show up there. We show a PSA that a high school student in Pennsylvania created. They throw up the opening pitch of the game. It's like really cool stuff, like people like this. But we also have a table, which happens to be near one of the gates. People are walking in, they stop by, we're passing out a bunch of free stuff. Kids love free stuff, but we pass out gun locks. Interestingly, the only thing we ever don't come home with at the end of the night is the gun locks. So if you have them and you're there at community events, those things work. But as far as the community engagement goes, what I'll say, we have a national strategy for suicide prevention in this country. It is very lengthy, 200 and something pages long. I'm going to summarize it in that word 3 times. Connection, connection, connection. The bottom line is this: people who feel connected to other people in their communities, in their families, in their schools, pick it. They find ways to get through more difficult times than people who feel alone and isolated and by themselves. So community engagement absolutely works, and you can do it in 1,000 different ways. All right, so working with local media, so here we go. Talking about the impact of messaging and why does it matter how we talk about suicide prevention. It makes a huge difference. If you've noticed, there hasn't been, thankfully, as much in the newspaper these days about, somebody dies by suicide. I can remember 10, 15 years ago, somebody in the school district dies by suicide. It's in the Inquirer, and people are reading all about it, and they're talking about it, and a whole bunch of conversations are happening about it, but we don't know what's coming from that. The problem was they used to publish details about what had happened. That's really not helpful. In fact, there are many, many studies out there that tell us that the details really don't matter and all they can do is actually be hurtful. So why is that? So this is a wonderful book from the late 1700s, The Sorrows of Young Werther. So this was an aristocrat. It's a fictional story about an aristocrat who grew up, who kind of moved out into a rural area to kind of start his life over again, made some friends out there, found this young woman that he fell in love with, and wouldn't you know, one of his friends ends up getting into this relationship with the woman that he believes is the person he's supposed to be with for the rest of his life, and so all of his love is not being returned to him. He feels like he cannot go on anymore, and he ends up killing himself. So the book gets published in the late 1700s, and people start reading this book, and because he's such an identifiable character that people want to be like, people are starting to dress like this guy. They're walking around like this guy, and believe it or not, it is the first media outlet of any form where we believe that there was about 100, if not more than that, suicides that were a result of people reading this book and kind of following along with what he had done. 13 Reasons Why. How much time do I have? Probably not enough, but it's interesting because when the series came out, so 13 Reasons Why was a series that was on Netflix 2 years ago. There was another season that was done last year. It was a book that was actually published in 2007 that they put into 13 one-hour or so episodes of this show. And Netflix did a great job of keeping this thing secret until the last second, basically, because I think they were worried what was going to happen. Those of us in the suicide prevention field were going to see this and go, oh, this is interesting. I'd like to see it, because if we can be helpful by telling people anything about this, not like don't watch it necessarily, but like how to resource, because we all know if you tell a kid don't watch it, they watch it. So like that isn't the message. The message is how do we as parents be more effective when it comes to our kids. So then it comes out. It comes out at midnight on April 1st, which is a Thursday going into a Friday. Immediately we know there's kids that are not going to show up at school that day because they're going to binge watch 13 episodes of this, and we put together a brief for every school district in Pennsylvania such that by Monday morning, every school district had resources and materials that they could send home to parents that they had available for them. And again, it wasn't about we never said don't tell your kids, or we never said tell your kids don't watch it. Because you know that that's just an invitation to go watch it. And some of the kids didn't know about it, so the last thing we wanted to do was say, let's publicize this even more. The thing about this show was this. It was really, really well done. I can sit there and imagine myself, a 17-year-old, watching this. I had to watch it, like professional liability, I had to watch it. If I were 17 or 16 or 15 or 12, I would have been watching this thing, this is fantastic. Because you know what? All that crap happened when we were in school too, just slightly different because we didn't have the same technology and it played out a little bit differently. But all that stuff happened in school. It just didn't happen necessarily to one person. Then you're really engaged. Like they did a great job. You're really engaged. And then you get to an episode where a girl gets raped and you realize that wasn't what I was expecting to see. And then a couple episodes later, you see it again. And in the last episode, she kills herself. And you know she's going to, because this is kind of the way, like she was dead at the beginning of the thing, and it's, anyway, I'm not going to go into the whole thing. The problem was they showed this scene of her killing herself where they didn't cut away from it at all. Straight from the beginning to the end. No sort of, dramatic flashback of her life, none of that stuff. And she died in a way which is interesting because it's not the way that was published in the book. It was much more gruesome than what was published in the book. And it was a method that is hardly ever used for suicide. So the interesting thing was, I called the medical examiner's office in Philadelphia because I've worked with them a little bit, and I said to him, so like, any chance that we can like interview people that die under the age of 30 in the next like month and a half, like their families, and see like, did they see this show, like what was going on? And of course, that was going to be a real pain, so that wasn't going to really happen. However, anecdotally, he could say, here's some cases, and oh, by the way, people have actually used this method, and I haven't seen that in years and years and years. That's a problem. So we've been sitting around for years waiting to see what was the impact of this particular show. What did they find? 29% increase into 10 to 17-year-olds dying by suicide in the month after the show came out compared to the 5 previous years. They compared it to all 5 of those years. They compared it to what they would expect to see in terms of normal fluctuations, in terms of increases by suicide. 194 more deaths by suicide in that age range in this country during that time than you would have expected to see. So what'd they do? Had a second season. And now they're going to have a third. It sells, apparently. But then there are other methods when we talk about media that really work. So I was at a conference a couple of years ago, and the director of the National Suicide Prevention Lifeline's a guy that I know pretty well, and we were talking. He goes, have you heard about this song that's coming out? Like, it was literally coming out like 2 days later. Have you heard about this song that's coming out? I was like, what are you talking about? So he gets a phone call from the manager of Logic. Well, we didn't even know who Logic was at the time, and so he's like, you're smiling, but you didn't know who he was 3 years ago either. He calls, and he says, listen, this song's gonna hit at the end of the week. It's a big deal. It's a big deal. Do you want to partner with us? We're gonna name it 1-800-273-8255. That's the phone number for the National Suicide Prevention Lifeline. It's gonna be a big deal. Do you guys want to partner with us? And he's like, can we, I think he told him he's a rapper, and I forget what else he went into it. And so this guy that I know who runs the Lifeline was like, can we see the lyrics? He goes, no, you can't see the lyrics. You're gonna have to wait till it comes out. And he's saying, I'm worried, and I realize I'm sitting here in a government building. I'm going to say what he told me. He said, I'm worried about how many F-bombs are going to be in this song about suicide prevention, because this is what his stereotypic belief is going to be about this message. He says, well, can we listen to the song? No, you got to wait till it comes out at the end of the week. Okay. He says, well, I guess we're going to have to partner with you because we don't really have a choice, do we? And so they do, and what happens? Logic puts out this song. It becomes #1 on the chart. Everybody hears it. Now, every time that song shows up on the radio in your car, if you have a car that like shows you the title of the song and the artist and stuff like that, the National Suicide Prevention Lifeline number is there again and again and again and again and again. The Video Music Awards came out. The calls increased to the National Suicide Prevention Lifeline. The Grammy Awards came out. He closed the Grammy Awards that night. The number for the National Suicide Prevention Lifeline was all over the television that night. Guess what? Calls increased to the National Suicide Prevention Lifeline. What happens when we publish the National Suicide Prevention Lifeline? We know that celebrity deaths have a huge impact. They get published. People are going to talk about it. The media is going to write about it. Why? Because it's somebody people know. We know that data shows that when Robin Williams died by suicide, there was an increase in suicide deaths. We know that when Kurt Cobain died by suicide years ago, there was a massive increase in young people's suicide deaths, particularly in the Seattle area. But this was the call volume that increased, because now when people are reporting about suicide, the message is, if you need help, call this number. And so when Robin Williams died, the call volume that week to the National Suicide Prevention Lifeline was 71,000 calls, all the way to just last year when Kate Spade and Anthony Bourdain died in the same week, 91,000 people called the Lifeline. That wouldn't have happened years ago because people weren't publishing the number and telling people this is where you can get help. My kids know the phone number to the National Suicide Prevention Lifeline. course, I got serious dad points when my now high school age kid goes, "Dad, you know who Logic is?" Because he thought he had one on me. He knows what I do, so he's like, "Dad, you know who Logic is?" And I was like, "Yeah." I also knew people who were on the stage on the Grammy Awards standing right behind Logic that night that he performed. And I got a text message about 2 minutes before the Grammy Awards from a friend of mine who says, "We've been under embargo. I wasn't allowed to say this, but watch the Grammy Awards tonight. I'm going to be on stage right behind Logic. It's at the end of the show." And so right before my kids went to bed that night, I was like, "See? You know what they said to me? How come you aren't there?" Thanks. Got to get you somehow, right? Means matter. So I've already kind of talked about firearms, but I want to just quickly hint on these things. This is looking at 2017 data, 10 to 24-year-old age group, and different methods for suicide death. So again, firearms is just under 50%. If you look at all ages, it's just over 50%, as I shared with you before. Suffocation is any form of asphyxiation, and so that's the second highest. Why does this matter? These are slightly older data, but what you can see, the right pie chart over here, is that I think this is 2015 data. Suicides accounted for over half of all suicide deaths, but it only accounts for about 5% of all suicide attempts. Why? Because it's a highly lethal method. So what's the message? We need to keep guns out of people's hands when they are in fact suicidal. This is not me standing on a soapbox talking about Second Amendment rights. I'm not talking about political issues. This is a safety issue. It has nothing to do with politics. These are data from a couple of studies that came out when they looked at people who had died by suicide using a firearm. The question is, where did they get it? And if you look at the data, it's pretty clear. It was in their house. If it wasn't in their house, significantly fewer people would go somewhere else to get a gun. And we always think, well, if somebody's suicidal, they're just going to go buy a gun. In fact, in Pennsylvania, the laws are a little obscure. You could just do this. Someone will just go buy it and use that gun. That almost never happens. If the gun is in the house, people use it. David Brent, who is a child psychiatrist, adult psychiatrist, and pediatrician in Pittsburgh, did a study several years ago where he compared youth who had died by suicide to youth who had made suicide attempts, survived the suicide attempt, and were in an inpatient psychiatric hospital. And he had lots of sophisticated data collection methods where he could talk to families and providers of those who had died, so he had lots of data on the people who had actually died. And he ran a sophisticated statistical model where he threw all of these things into an equation because he wanted to know what predicted if somebody was in the group that lived versus in the group that died. And the only variable that predicted which group you were in is if you had a gun in your house, you were 2.5 times more likely to be dead than if you didn't. That's the only thing that made a difference. Didn't matter how old you were, didn't matter where you lived, it didn't matter, what school district you went to. None of that stuff mattered. It didn't matter about dating, it didn't matter about single parent family. None of that stuff made a difference. The only thing that mattered was if you had a gun in your house. But there's lots of other lethal means restrictions. So the firearms, we talk about distribution of gun locks. I mentioned that before. We pass these out at baseball games. People take them. Kids think they are bike locks. They kind of look at it strange. The parents kind of walk up behind them, and their parents kind of go, "Oh." And we go, "Do you need one?" They go, "Yeah, I think I'll take one." "Do you need more than one?" She said, "Oh, I'll take 3. Good. Here you go. The thing about firearms and gun safety is that people assume that kids don't know the lock. They don't know the safe lock code combination. Then you have to remember that there are plenty of variables that contribute to adults teaching their kids how to shoot guns, such that by the time they're 13, 14, sometimes younger than that, they already know the combination of the safe because they get the guns out and clean the guns before they go to the firing range. We have gun locks because we think it protects our 3, 4, 5, and 6-year-olds from accidentally shooting themselves. That's true. We forget about the fact that when they're older, they sometimes turn that gun on themselves. Gun Shop Project is something that we're working on in Pennsylvania. It started in New Hampshire. The idea is really, can we work with people who own gun shops? Can we work with people who own firing ranges? Not to tell them don't give a gun to somebody, but provide information about safe storage of firearms. Because if the conversation is about don't sell a firearm, nobody wants to participate. But if the conversation is if you own a firearm, here's how to keep it safe. If you're concerned about somebody, you have that. Train safety is another thing that we can talk about. That's probably one of the more challenging things. There's lots of trains in Pennsylvania. And look, train line, there's 2 of them that go right through here. I ride on one of them every single day. how do you reduce access to those kinds of things? Medication return. Work with the local hospitals. Go to Bryn Mawr Hospital and say, listen, I was one of those people who got prescribed something that, when I was ill or injured or whatever it was, and I've got a bunch of it left over, and I have no idea how to get rid of it. I don't want to just throw it in the trash can. I'm worried somebody's going to get that, and so what can I do with it? They'll take it back, but work with the hospital to put these kinds of things in there. Medication return drop boxes, they stick them usually in the emergency room right next to the security desk because people will stick their arms down in there. So you put that stuff in there, and it gives you a safe place to go and return medication. Most of us in this room probably have something in their house that they don't actually need anymore. I have been guilty years ago of going to Costco and buying the 500 count of ibuprofen because I thought like $15 was a great deal. And that maybe the back pain was going to last for the next 20 years. But you don't think about the consequences of that. And they just, it's there in case I need it. Jump barriers. A couple of things. So this is a picture at Cornell University. They had a problem for years and years and years of students essentially jumping off of these bridges that went over the gorges between the different sides of the campus. And they figured that the only way they can solve this problem is prevent them from jumping over the barrier. So what did they do? They put these nets around it, but it wasn't a net that went under the bridge. It was a net that wrapped around itself over the top. You couldn't get around the side of it if you tried. Guess what? Nobody's jumped off of those bridges since they did that. Historically, though, what I'll tell you is that there are places that have done this on bridges before. What happens is they look at the data and they go, guess what? Nobody's died in a long time. Let's take it down. You guys know what happens, right? Yeah. San Francisco, I went to a conference on suicidology there in 2008. That was the year they passed the law to put the net under the Golden Gate Bridge. Has anyone seen the net there yet? As of last year, it was not there. 10 years later. People say, okay, well, one of the more likely places, certainly on college campuses, that people die by suicide are like parking garages. So what do you do about that? Like, you can't do anything. They think build up. Build up never works. Just means you go higher to start with. What works is simple things that people don't think about that cost a whole lot less money. If you plant trees under the most likely places where they're going to jump and stick things like awnings underneath that, you know what happens? Somebody goes, I might not die. You know what happens? Then they think, if I don't die, I might get really hurt, and that's going to really suck. And that bit of doubt prevents people from jumping. It's simple. Plant a tree, save a life. Continuity of care, we know there's major gaps that exist. One of the biggest problems that we have in this country is that we can get sometimes people from point A to point B, but then sometimes they need to get to point C and we drop the ball. Somebody in your school district can have a parent come up to them and say, listen, I'm worried about my son. Can you recommend somebody they can go talk to? The school district could say, hey, you can call me. See, the problem is I don't know that the person's ever been given my phone number, so when they never call me, I don't know that I'm missing out on anything. If they don't call me, is that because they didn't want to go? Maybe. Is that because the parent thinks things are going to get better? Maybe. Is that because I don't accept their insurance? Maybe they looked that up and figured that out. I don't know what it is. Point is, I don't have a clue. So there's a gap that often exists between identifying somebody, referring them somewhere, and getting into care. Then they get into outpatient care, and sometimes they need a higher level of care. Then there's a gap that exists there. What happens there? They get discharged from the hospital, and everyone's like, oh, they're going to be fine. Where are they going? By the way, they stuck them on 3 medications in the hospital, none of which are actually on their insurance plan. They can't afford to pay for any of those things when they get discharged, and so they stop taking them. That might be okay, or not. So we need to improve access. We need to improve communication, and it's something that, again, it's not a simple thing to solve across the board, but it's definitely an area that we can work on. Some important resources I want to share with everybody. I've already kind of talked about the National Suicide Prevention Lifeline. If you're worried about anybody, these are 2 numbers that you should give to every single person you're concerned about. The first is the National Suicide Prevention Lifeline. You can call that number 24/7, 365 days out of the year. You may not get somebody answering the phone right here. In fact, I know for a fact they're not going to answer it right here. But somebody will answer the phone. Now, you might need to tell somebody, listen, it's going to ring for a little bit. They're busy. They will get to you, and the person that answers the call will be able to help you, but you need to hang in there, find something to do while that phone's ringing, because it sometimes rings. There's a crisis text line. We know that young people don't like use their voices. They use their thumbs to talk to each other. They sit next to each other and have like thumb conversations. There's a crisis text line. You can text PA to 741-741. You can text anything you want to 741-741. It will start the conversation. But if you text PA, we have the ability to see some of the data, not the actual transcripts of what people are saying, but we have the opportunity to collect some data. You get a sense as to how old the person was, but you certainly get the first area code and the first 3 numbers of their phone numbers, which will tell us within a reasonable distance where they live or where they're from, which tells us a little bit about who's using it and where they're using it. And then I work with Prevent Suicide PA. We've got a ton of stuff on our website. Feel free, jump on there, take a look at what's going on. This is me. That's how you get in touch with me. I talked, it was about 35 minutes, but I'm happy to stick around and answer questions. I know it's 7 o'clock and you guys have other things to do tonight, but I'm happy to answer any questions that you might have.
I wanted to give you a round of applause.
Oh, thank you.
Thank you, that was outstanding. I learned a lot, so thank you. So do we have any public participation or questions? We have a great group.
Yeah.
Can you go back to, you said the guns are so much more lethal and keeping them out of the hands of people who are suicidal is so important. And I was speaking a little bit earlier about the red flag bill in the state of Pennsylvania.
Mm-hmm.
And the biggest holdup for that has kind of been in a holding pattern over a year now.
Right.
What are you doing? What else can be done that will convince the other parts of the state? All of our local legislators are sponsors of it or
Right.
signed on to it already.
Right. So just because the recording is, I'm going to repeat the question a little bit. You're talking about extreme risk protection order laws and stuff like that. So there are a number of states across the country that have these laws, and essentially what they do, if there's certain people. Let's say I'm a law enforcement person. I'm worried about the safety of somebody else, that they might be a threat to themselves or to somebody else. I can then petition to have basically their guns removed. So this is what the law says. There's a number of states that have it. There's a lot of different versions of it, which complicate things. I think people recognize that that could be useful and helpful because, it's different than, giving up your guns and like never seeing them again. You do get them back. There are some challenges with it, as you can imagine, politically about all of this stuff because some people just never want to give them up. I think one of the challenges that we have in Pennsylvania, perhaps, though, too, is there's a minimum amount of time at which the guns have to be withheld from that individual. The proposed time in Pennsylvania is a lot longer than some other states, and I worry that might have something to do with why it's being held up. I don't know that for sure, but I'm worried that could be a part of it. Like I know, for example, in Maryland, it's like 14 days. You have a hearing in 14 days. If they are not concerned about you, then you get your guns back in 14 days. In Pennsylvania, I don't want to give I'm not 100% sure. It's a lot longer than 14 days, though. So it's challenging. I think we have to go in multiple directions. We're also a state that you can't just sort of walk in. I mean, you can self-surrender your firearms, but then, like, you don't get them back. Mandatory. Right. Yeah, we don't have, right. There's a lot of issues around guns and stuff here in Pennsylvania. I can't speak to them as intelligently as I'd like to, so I'll just say we have some challenges to overcome. And this part of the state is less. Yeah. You're welcome. Other questions?
I do have a question,
Yes.
and that is when you go to distribute brochures, information, leaflets about suicide prevention, most people will look at it and walk away.
Right.
Is there any way to overcome that problem? Rewrite the literature so that it's, for lack of a better term, more attractive, or
Right.
how would you handle that?
You have to make it realistic. And if you just throw numbers in people's faces, they see numbers in their, like if I started with that big slide with all, the green and the blue and the red and all that other kind of stuff to a huge public forum, people would, like, their eyes would gloss. Unless you were a public health person, your eyes would just gloss over and you'd be like, wow, that's too much data. I think the message that people need to hear is suicide can affect anybody. If I actually broke the data down by age and a whole other list of variables, what you find is there's no group that's immune. And because of that, it could affect anybody, and therefore it could affect you. I think as a parent, our biggest challenge sometimes is when our kids say that they're struggling, we think it's just a teenage thing. They're going to get through it or whatever. They'll be okay. And they might be okay. But we have to do a better, I think the message that we have to give the public is if something happens that you're worried about, here's what you can do. And then tucked in that is, here's some other things that you need to know. People want to know how to be helpful. And I think in some communities, it's challenging because people don't want to come to an event where they hear about it because they're worried that if I show up there, people are going to think, oh, then I'm saying I'm worried about my own kid. We also have to remember we live in neighborhoods where our kids' friends show up at our house all the time. You know, maybe it's about them. How can we help our neighbors out? You know, whether you go to church or synagogue or whatever, there's people that you know there too. What happens if you're worried about somebody there? How can you be helpful to people? I think people genuinely want to be helpful to other people. It's just when they get messages that start with numbers and suicide prevention and like in your face, they get scared because no one wants to have to deal with it.
Oh, no.
10 to 14, yes. Mm-hmm. So I'm going to give you a website because I could give a whole long talk on what are the warning signs. The warning signs for youth probably vary a little bit as kids age. What I can tell you is the best thing we have out now is a consensus list of warning signs for youth. And so if you go to, you ready? It's really simple, youthsuicidewarningsigns.org. We got all the national organizations in the country to get behind this project where we basically had 25 international experts sitting in a room talking about what do we know, you know, what do our data tell us, you know, and so on and so forth. And we came up with a consensus list of warning signs for youth suicide and published it under this youthsuicidewarningsigns.org site, which all the other sites then kind of direct people to, so that everyone has the same message. I can give it to you in a very quick nutshell. People talking about suicide is concerning. Sense of hopelessness. The thing with people that are suicidal, it's not that they start out hopeless. They are desperately trying to get better. No one wants to be suicidal. They're desperately trying to get better. And for whatever reason, all of their efforts in their own minds seem to not have been working to the point where they feel like they're hopeless. There's a sense of overwhelming emotional pain. And then there's some behavioral cues that are worrisome, which have to do with kind of disconnected from other people, kids that are not usually angry and irritable, getting angry and irritable for seemingly no reason, acting out of character, out of context, and they usually do, and then sleep, which is you know, with teenagers is a real challenge. It's not the kid who's staying up all night watching Netflix, it's the kid who's going to bed at a normal time, can't fall asleep until 2 or 3 o'clock in the morning because they're trying to solve life's problems before they fall asleep, and then they basically run out of gas, go to sleep, have to get up at 6 o'clock, go to school, the next day and they're sleeping in school. And what happens at school? Wake up, not, hey, is everything okay? So that website has a lot of that stuff as well as resources for parents and stuff on how to address those things with your kids. Yeah. Yep, Jordan came out to my university the other day. I know Jordan. Lives in my town. Mm-hmm.
Do you want to come up and you can give a little information, because I think it sounds very beneficial.
Hi, my name is Maura Wheeler. I live in the township. I also work for Minding Your Mind, which is an Ardmore-based nonprofit that does mental health education and suicide prevention training, mostly in schools. We also do community organizations and workplaces now. We have certified QPR instructors. If anybody's interested in school for the education or the township or doing a community event, we do QPR training where our certified instructors come in, go through that program, talk about suicide. There are a bunch of different programs there, but we are local. If you have kids in the school district, very likely they have seen one of our programs in one of their schools. And as Dr. Winterstein just said, he knows one of our speakers very well, who I bet you do. I bet you do. So it's a local resource that's available to you. We have a lot of resources on our website too, locally, counseling organizations that We don't provide counseling, we provide the education piece and then put you in touch with resources. So if anybody's looking for resources or follow-up or want to hold a community session about it, we'd be more than happy to talk about that.
Thank you. Dr. Witterstein, as far as that red flag law, one more time, just was something you said stuck in my mind. You said law enforcement can ask, but also can't parents ask?
It depends on how the law gets written. I think so. I can't remember off the top of my head. Is that, you don't know? Loved ones? Yeah. 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 I'm just glad mental health professionals are not on the list. Because I would rather you come to me and say you're thinking about suicide and, oh, by the way, you have a gun, than to not tell me one of those two bits of information. No, not the way it's written. So the problem, like I said, the problem is, as a mental health professional, the problem is if I'm required to do something specifically, if you say both of those two things, you won't tell me one of those two things. That's problematic. I'd rather know both of those and figure out how to work with it than not. Just, we can have a longer conversation about it, but just trust me, it gets complicated. Glad I'm not on the list.
Yes, there is a drug, I wanted to mention that as well.
Oh,
We do
cool.
have a medication or drug drop-off box here in the township, correct, Superintendent? Downstairs.
That is
So-
correct,
Yep.
24/7.
Mhm.
And we participate with the DEA as well. They do some work where we go out in the community.
Good.
and pick up areas like-
As well as one at Bremer Hospital, right outside the emergency department. So I'm familiar with that drop box.
Perfect. See, like these, interesting thing, these are simple kinds of things, and they're terrible. They've been shown to be effective. They've been shown to be very effective. We think it's for another reason, which it probably is as well, but the point is it's helpful for suicide prevention too. You guys cut me off when the time is. 'Cause yeah.
Another plug, we have unlocks out of the table right out in the lobby, and Radnor Police Department has always here, work with local residents people purchase a supply of, you get 500 and then they match it for another 500, so we do have unlocks that can be met at any time. You can know if you're at.
So for the people watching at home, the plug is come to the Radnor Police Department, get your free gun locks. Okay.
Or you can ask them and they'll bring them.
Or ask them and they'll bring it to you. Wonderful.
For everybody on the board, too, this is Sarah Wallace, who has the Be Smart training for keeping your guns. What is it? It's an acronym that it helps facilitate these conversations among families or with research about recognizing the risks of suicide, smart, responsible gun storage, really making sure that the focus is on the gun owner, the parents, the weapon, not for the child.
You're welcome to come up if you want to speak. It'd be great. Come on up.
So Be Smart, like I said, is a nonpartisan program. It's really a gun safety program that helps facilitate conversations about guns and gun safety among families. So you may be a responsible gun owner and keep your guns and ammunition separate and safely stored, but what happens when your child goes to someone else's home? Are you able to, it teaches you how to have conversations. Like one example is my kids have a bunch of allergies. So if we're going to a play date at a new family, who we don't know, just FYI, my kids have, they're allergic to peanuts, tree nuts, eggs, sort of working it into a conversation like that. Like we don't have any peanuts, or we're peanut-free, tree nut-free, pet-free, gun-free. Like there are ways, like texting even, that you can sort of work these conversations simply into everyday interactions. But it goes into some of the safe storage as well. It's online, besmartforkids.org. So the acronym is there. All the training resources are there online.
Thank you very much. I saw your video with Superintendent Flanagan. It was excellent, the YouTube video.
It's meant to be very approachable for families and kids.
Thank you.
Dr. Wintersteen had really, that's truly the most informative talk that I've ever heard on suicide prevention. It was really outstanding, and I think all of us are so grateful for you to spend the time here today with us. I learned a ton as a father of 3 boys here in the township. I learned a lot. 2 things. First, if there are parents in our township that are concerned and find some of those warning signs, what's the most useful way for them to go about it, kind of next steps for them? And that's my first question. And the second question is, if you talk to folks that have tried to commit suicide, and then you ask them, I don't know if you know the answer to this, what would have helped them not try?
Yeah.
Is there data that we can learn from that population?
Let me go with that first, and then I'll go back to your first one, right? Most people that have attempted to end their own life will often have stories that say, I wish I hadn't, like, there's a lot of shame, a lot of, I wish I had not done that, a lot of times they feel alone. They feel isolated. They feel like they are a burden. Like I said in the one myth, they feel like they're a burden on other people. Like we seem to think it's like they want to be away from us. And I think by and large what you find is it isn't that they want to be away from us for them. They want to be away from us because they think it's going to help us in some way. They're creating problems for us. Therefore, if they die, then we're alleviated of whatever these problems are, which is not the case at all. The problem, of course, is we don't know that that's what they think. And therefore, it's impossible to say, hey, listen, I just want you to know that, what you can do, tell your kids that you love them, go give them a hug. They matter, it's important. But for them to feel like, yeah, you take them to 20 soccer practices a week, I do. But I love doing that. And I love doing that with you. And, that they matter and that are important in some way. So they don't feel like they're being a burden in some way. And I get it. I mean, I can say all those things and listen, there's always exceptions to everything that's said. And suicide prevention is so idiosyncratic sometimes that I couldn't say always do this and it always works. I wish I had that answer. It doesn't work like that. But I think helping people understand that they're not a burden on others is incredibly important. And helping them feel connected to other people when they feel alone and isolated, and giving them some skills and resources by which to do that. Your first question, though, I think was about parents and what could they do. I've got a great video on this. It's I'm trying to think of how to direct you to the most simple thing. I'll give you a 3-minute video. Go on YouTube. My kids realized I was on YouTube too, and they're like, oh, Dad. Like, I get some serious dad points, and then I get the why aren't you doing this, and yeah. If you search on YouTube for, I think, American Foundation for Suicide Prevention put together, so if you search for AFSP, and it's like, are you okay, with a question mark after it, you just search that, I think, you will find it. And it's a 3-minute video. Basically, they'd asked me to talk about research once at a conference, and they were like, can you talk about why everybody should be funding AFSP for research and stuff? And I did that, and then they said afterwards, is there anything that you're working on these days that we should tell people about? I was like, well, we've got this thing that we should tell parents, like if they're worried about their kids. Like, oh, just go ahead and talk. And so I talked for like 3 minutes. They recorded it, and that's the thing that they didn't run with any of my research comments. They wanted all of that kind of stuff. It's like 3 minutes, 4 minutes tops. But it's simple stuff, like we need to do a better job of asking people. We're so afraid of what the answer is that we never ask anybody how they're really doing. And so the consequence of that is we assume that they're okay, or they're just going through something and it's going to be okay. That's the first one. The second one is, as I said before, when we're worried about somebody and you ask somebody if you're okay because you're worried about them and they say, I'm fine, don't accept I'm fine. I'm worried about you because A, B, C, and D. And then as parents, the most important thing we have to do is shut up and listen. We try to solve problems by talking. It doesn't always work that way. We'd like to think it works that way. It doesn't always work that way. So we be quiet and listen, reflect back to them what they have shared with us, tell them that they're not alone. People that are suicidal desperately want to tell somebody how they're feeling. They believe that they're alone in it. And you now knowing this information from them doesn't mean that you're going to solve their problems for them. It means that deep, dark, hidden secret that they've had that they feel so ashamed about now lives with somebody else too. so they're not alone. There's treatments out there that are actually effective and helpful that they can get. And guess what? If you go see somebody and it doesn't work for you, you didn't like that person, it doesn't work, whatever, go see somebody else. And if that doesn't work, go see somebody else. I had somebody in my office a couple of months ago, teenage boy comes into my office, and he's like, I've seen 4 people in the last 3 weeks. And I looked at him and I was like, I probably suck too. And guess what? He's perfectly fine chatting with me now. But it's letting them know that there's things that work. And then the last thing is obviously guiding them to the help that they need. But it's all in this video. It's pretty simple, and it's quick and easy, and parents can watch it, and it works out well.
Well, we'll take a look, and we'll see if we can get it loaded onto our website.
I don't own any of it. Knock yourself out.
All right, great.
Give it away for free.
Any other questions? Public participation? All right, well, thank you, everybody, for your attention, and thank you, Dr. Winterstein. Thank you so much. It was excellent. All right, if there's no other feedback, meeting's adjourned. Just to note, our next meeting will be Monday, September 16th at 5:30 here, so have a happy and safe summer, everybody, and we'll post the information on the website. If these student interns, I thought we could take a picture.